Eu sou Andresa Feitosa Ribeiro, sou hematologista do Hospital Albert Einstein e quero agradecer muito a presença de vocês e o tempo para discutir um pouco um assunto tão importante e interessante que é o uso de CAR-T-cell em linfoma difuso de grandes células. A gente sabe que não temos ainda disponível nenhum produto de CAR-T-cell comercial no Brasil, mas isso talvez já seja uma realidade no próximo ano. E o objetivo nosso aqui é pensarmos juntos e ouvir de especialistas que já fazem uso como colocar e pensar nessa possibilidade terapêutica em frente a um paciente com linfoma difuso de grandes células, recidivado e refratário. Eu trabalho com transplante de medula óssea há bastante tempo e estou muito empolgada com essa nova terapia. E para discutir esse assunto, né, a inserção dessa possibilidade no algoritmo de decisão de um paciente com linfoma difuso recidivado, refratário, nós temos o prazer de ter o Dr. Charles, que é professor assistente do Departamento de Clínica do City of Hope, na Califórnia. O Dr. Charles trabalha há muito tempo com linfoma e faz parte do time de terapia celular. E nós vamos discutir um pouco a experiência que ele teve no uso do CAR-T-cell em linfoma. E para isso a gente vai primeiro apresentar um caso clínico, de um caso clínico real que nós tivemos no hospital, e depois ouvir um pouco a apresentação do Dr. Charles e depois discutir. Por favor, façam perguntas, utilize o máximo esse tempo. Então, sem demorar muito mais, eu vou apresentar o nosso caso clínico. Então, eu vou apresentar o caso em inglês, em referência ao Dr. Charles. Então, o nosso caso in 2013, Mr. S.E.G., a 54-year-old man at the time, was diagnosed with diffuse large B-cell lymphoma, ABC subtype, 4B stage. The only comorbidity of this patient was type 2 diabetes. He was treated with 6 cycles of R-CHOP and achieved a complete response at the end of the therapy. After 3.5 years in remission in March of 2017, he presented with thrombocytopenia. A PET-CT showed a cervical SUV of 80, mediastinal axillary lymph nodes measured up of 1.5 versus 0.7 centimeter, with SUV of 7.4 in splenomegaly. Further PET-CT in October 2017 indicated increase in the number, dimensions, and degree of FDG uptake. SUV now 17.5 in the lymph nodes. A biopsy of the cervical lymph node and bone marrow confirmed the relapse of lymphoma, ABC subtype, stage 4. So you can see the first PET-CT on March. Maybe the team decided to wait a little bit and repeat some months after. And you can see the very large splenomegaly. So this patient was treated with salvage therapy, 3 cycles of RIs, and achieved complete response. The first mobilization attempt have failed, and after second mobilization with G-CSF and Plerixafor, a sufficient number of CD34 cells was collected. An autologous stem cell transplantation of CBV conditional regimen was performed in June of 2018 outside the Hospital Albert Einstein. In February 2019, he presented with cervical, axillary, and inguinal lymph node enlargement in Suero. A PET-CT showed increased dimensions and hypermetabolic cervical and thoracic lymph nodes, suggestion of active lymphoma. Deville a criteria 5. New biopsy carried out in July 2019, and the second relapse of DLBCL was confirmed. He received a new salvage regimen chemotherapy with 4 cycles of dexamethasone, cytarabine, and oxaliplatin. At the end of this protocol, the PET-CT imaging showed stable disease. maintain the same SUV uptake in lymph node chains. In January 2020, we received rituximab plus lenalidomide. After a few days using lenalidomide, the medication was withdrawn because of intense allergic reaction. At the time, the medical team discussed two options with the patient: autologous CD19 CAR T-cell therapy or allogeneic stem cell transplantation, hypoidentical one, because the patient didn't have any match donor. So this is the case, and I'd like to invite and thank again Dr. Charles, Dr. Charles, to present his and talk about, show his presentation, and after that, talk with us about his experience and maybe give us some tip how to build up our cell therapy program in São Paulo, Brazil. Thank you, Dr. Charles.
Thank you. All right. So today I'll be talking about CAR T-cell therapy for diffuse large B-cell lymphoma. Just as a disclosure, I am a speaker for Kite Pharmaceuticals. So a brief outline about what I'll talk about, a little bit of background on diffuse large B-cell lymphoma and the treatment paradigms currently, and then talking about CAR T-cell therapies for DLBCL, comparing the currently FDA-approved products, talking in detail about patient selection, bridging therapy, and then briefly about toxicities. So the objectives after the talk would be summarize the current treatment paradigms for DLBCL, understand the role for CAR T-cell therapy currently in DLBCL treatment and potential for the future, understand the principles of the patient selection, the difference between the 3 FDA-approved CAR T-cell products, basic principles of bridging therapy, and the main toxicities. So as I'm sure we're all aware, non-Hodgkin's lymphoma is the 7th most common cancer. These are US statistics, so there's about 70, almost 80,000 new cases reported in 2020, and almost 20,000 deaths associated with non-Hodgkin's lymphoma. And by far the most frequent subtype is diffuse large B-cell lymphoma. You can see the large orange subset, almost half. And that represents about 18,000 new cases per year in the United States. And although DLBCL is a single diagnosis, the World Health Organization is now recognizing that there's actually multiple DLBCL subtypes. And in general, with genetic testing, gene expression profiling, whole genome sequencing, we've figured out that DLBCL is actually a much more complex and heterogeneous disease. Despite that fact, and the fact that it is clinically aggressive, for the most part, it can be largely curable. So in speaking to the heterogeneity of DLBCL, in 2000, this study was published looking at gene expression profiling of hundreds of DLBCL samples from patients. And you can see that they were able to subdivide into 3 groups, most important groups being activated B-cell type and germinal center B-cell type. In general, the ABC type was less responsive to chemo with worse outcomes and more addicted to B-cell receptor signaling, while the GCB type tended to have better outcomes with chemo. Since that time, things have become even more complex, with several published studies retrospectively analyzing multiple dozens and dozens of DLBCL samples from patients, doing whole exome sequencing, identifying many more subtypes of DLBCL with specific genetic signatures, and potential therapeutic targets outlined here in this table from right in 2020. And I'm sure as time goes by, we'll be able to subdivide these even more. But despite this heterogeneity, DLBCL can often be cured just with combination chemotherapy. So this is a classic study by Kofir in 2002, looking at CHOP plus rituximab versus CHOP in elderly patients with DLBCL, showing that improvement in survival and hitting more than 50% survival at 3 years. But what happens to the rest of the patients who don't respond, or the patients who relapse after initial remission? So this is kind of a simplified diagram looking at prior treatment paradigms for fit patients and where they end up. So at initial diagnosis, standard first-line therapies are CHOP for patients who can handle it. Majority go into remission. About 45% will either have primary refractory disease or relapse. 55% will potentially go on to have what we would consider cure. In that refractory disease, patients typically get salvage chemo, and in remission, they can go on to get salvage auto transplant, consolidation, adding another 10% of that total from the beginning to what could be considered cure. And that leaves us somewhere around 35 to 40% of patients who have very difficult to control disease. So this diagram is a bit more complicated, but the same idea. So this was taken from a large retrospective study from Crump, looking at outcomes of patients with DLBCL that were either relapsed or primary refractory, and their outcomes with time. So first-line treatment was R-CHOP, and as I described, about half of patients went into remission, half were relapse refractory. Relapses could occur late, early, or be primary refractory, and patients would be considered for stem cell transplant. And some patients would be ineligible for transplant, and they would get second-line therapy, clinical trial, palliative radiation. Of those going to stem cell transplant, some would be chemosensitive and be able to get transplant and go into remission. And they would join this group here as an effective control of their disease. But a significant proportion will relapse or be refractory and require third-line therapy. And looking at how these patients did, primary refractory disease that was refractory to second or later line, and patients who relapsed early post-auto transplant all did very, very poorly overall. So the event-free survival was very low, somewhere around 15%, with a median overall survival of 6 months, a CR rate to subsequent lines of therapy of only 7%, with about a quarter having some response. So what do we do now in this situation? So this is where CAR T cell therapy comes in. On this slide is a diagram from a review paper in Nature in 2018, showing the different CAR T constructs that have been generated. First generation is shown here, and second generation, the important difference is the addition of these co-stimulatory molecules. All of the commercially available CAR products are second generation CARs. They have their external SCFE region, which is able to target whatever specific target the CAR is generated against. And then there's a hinge, a transmembrane domain, and then this co-stimulatory domain, which helps the T cells proliferate, become active, and then the internal signaling domain. Third generation CARs contain both co-stimulatory domains or some combination of those, but none of those are currently commercially available. And then looking at a normal endogenous T cell receptor here on the left-hand side for comparison. So this diagram came from Novartis Pharmaceuticals. So this is the Kymriah CAR shown here in this diagram, with the 4-1BB co-stimulatory domain and the CD19 targeting domain out here. And it kind of takes you through the steps that a patient and their cells would undergo during the production of CAR T cells. So leukapheresis, then they're sent to the manufacturing facility where the T cells are activated and transduced. The CAR They're expanded and then sent back to the patient who undergoes lymphodepleting chemotherapy and then T-cell infusion. And we'll see another diagram that shows all three products in a few minutes. But currently, in the United States, there's 3 FDA-approved CAR T-cell options. They're listed here. So Axi-cel, Tisa-cel, and Lysa-cel, which is Yescarta, Kymriah, and Breyanzi are their commercial names. And taken straight from the FDA label are the indications that I've shown here. So for Axi-cel, it's adult patients with relapsed refractory large B-cell lymphoma after 2 or more lines of therapy. So as soon as they could get it as 3rd line. Includes DLBCL, primary mediastinal B-cell lymphoma, high-grade B-cell lymphoma arising from follicular. So those are the 3 main subtypes covered by Axi-cel. Tisa-cel is very similar. Again, after 2 or more prior lines of therapy, diffuse large B-cell lymphoma, as well as transformed follicular. And then Lysa-cel is a little bit more broad in terms of its indication. So again, after two or more lines of prior therapy for DLBCL, but it includes DLBCL arising from any indolent lymphoma. So that would include transformation from marginal zone, Richter's transformation, and those are not included in the FDA label for the other 2 products. They also include primary mediastinal B-cell lymphoma, just like Axi-cel does. And they're also unique in that they included follicular lymphoma grade 3B in their study. So this table kind of breaks down some of the important differences between the 3 products. So at the top, you can see the 3 products are mentioned: Tisa-cel, Axi-cel, and Lysa-cel. The names of the trials that led to their approval, so Juliet, ZUMA-1, and Transcend. The number of patients that were analyzed in those 3 trials. The target, which is CD19 for all 3 CAR constructs. And then the specific diseases that were covered in their inclusion criteria and for which they have FDA approval for treatment. So the most limited is Tisa-cel with diffuse large B-cell lymphoma and transformed follicular. Axi-cel also has primary mediastinal in their label. And then Lysa-cel has the most broad label, including transformed from all low-grade lymphoma, and then follicular 3B. And they also included several patients who had secondary CNS disease, and that was also unique to their trial. Lymphodepleting chemo was Flu/Cy in all 3, but Tisa-cel also included bendamustine as an alternative option. Bridging was only allowed in the Lysa-cel trial, not in the other 2 trials. And then looking at overall response rates, the highest was with Axi-cel, but these were not head-to-head trials. So it's impossible to draw a conclusion of potentially which one may be more efficacious. And then CR rates were very similar in the mid-50s percentage in each trial. As far as toxicity, highest rates of grade 3 and higher CRS were seen in the Juliet trial with 22%, around 11% in ZUMA-1, only 2% in the Transcend trial. And then neurotoxicity grade 3 and higher was seen highest in ZUMA-1 at 32%, and then about 10% each in the other 2 trials. And then looking at other types of toxicity, neutropenia was reported beyond day 30 in 40% of patients in ZUMA-1 and 60% of patients in Transcend. And that's an important toxicity that you have to be aware of in patients after they come back after CAR T-cell therapy, because the cytopenias can persist for months, sometimes years. Infection rates grade 3 or higher were the highest in Axi-cel, around 28%, 22% in Juliet, and 12% with Lysa-cel. So comparing the CAR constructs side by side in this diagram, you can see Axi-cel has a CD28 co-stimulatory domain. The other 2 have 4-1BB. And then the transmembrane domain is the same for Axi-cel and Lysa-cel. They all have different hinge domains, but they all have the exact same murine scFv fragment for targeting CD19. And then looking at the process for CAR production. Patients undergo leukapheresis with their starting material. It's different depending on the product. Fresh PBMCs for axi-cel, cryopreserved for T-cell, and lysocell separates out CD4 and CD8 T cells. The CAR loading is retroviral for axi-cel and lentiviral for the other two products. And then they use different expansion drugs in order to expand the T cells. And then the goals for infusion are different depending on the product. So looking at how well these work, we already saw the overall response rates were excellent, upwards of 70 to 80% in patients who previously only had responses in the 25% range with chemo and other standard options. And you can see that the survival is excellent as well. This is overall survival from the Kymriah trial, Juliet, and you can see extending out to 33 months, more than half of patients are still alive at this time point. Actually, I apologize. This was axi-cel. This one is T-cell. So in this graph, they look at overall survival and then look at patients who had complete response and all patients. You can see all patients going out to 22 months was just under 50%, and those who attained a complete response, around 70% were alive at that time. And very similar, looking at again at patients on lysocell, the overall survival of those who attained a CR versus all patients, both are excellent, going out to 42 months. And if we compare that to the SCHOLAR-1 trial, which I mentioned earlier, where the response rates were very low, just with standard salvage chemo, you're seeing survival rates like only about 15% going out that far. So now we can modify this kind of treatment paradigm after patients undergo first-line R-CHOP and relapse, and they undergo a second salvage treatment. At that point, and if they still have disease, or if their disease is progressing or relapses after that, CAR-T is really the most efficacious option right at that time. So how do we select patients who will do the best and will have the most optimum outcomes with CAR-T cell therapy? And we can look at these various factors that were analyzed in subgroup analysis of the various trials and have also been studied in retrospective studies, and data has been published on. We've also looked at some of these at our institution as well. So starting with age, interestingly, age does not seem to be a primary determining factor of outcomes. At our institution, looking at older patients, they may have slightly increased rates of neurotoxicity, but the response rates and efficacy remain excellent. There is, in some cases, a suggestion that maybe they respond better than younger patients, but that hasn't been proven. So these are subgroup analyses from the three major CAR-T trials that I've been discussing so far. And you can see there's no significant difference between patients under the age of 65 or over the age of 65 in any trial. So age is really not a determining factor of outcomes with CAR-T cell therapy. The oldest patient we've treated here is 84. And I think we've treated at least a dozen, maybe, yeah, at least a dozen patients over the age of 75, a handful over the age of 80. Looking at disease subtype in terms of DLBCL versus the other transformed lymphomas, one of the considerations that's important is looking at the inclusion criteria on the specific trial. And I'll show you the table again after this. But looking at the high-risk subtypes, it does seem like CAR-T cell therapy may be an excellent equalizer. For example, we know that double hit or triple hit lymphoma typically does poorly with chemo and has high relapse rates after autologous transplant. And we know that ABC subtype typically does worse with chemo. But looking here, ABC and GCB subtype do very similar with CAR-T cell therapy. in 2 of the trials. And then this trial also analyzed double hit and triple hit lymphoma, and they all responded very well. And we see similar trends at our institution too. And then again, looking at disease types that were treated on each of the trials, if you had a patient with primary mediastinal B-cell lymphoma, you would want to consider axi-cell or lyso-cell, since they weren't included on TISA-cell. And then if you had somebody with secondary CNS involvement, they were included in this trial, so that'd be something to consider. Transform marginal zone, you may, excuse me, you may want to treat here as well. So those are all things to consider about how to differentiate between those different products. Bulk of disease. So there's some evidence that CRS grade may relate to the bulk of disease and have to do with how significant an initial response the CAR T cells have to the lymphoma. So there may be some benefit in reducing CRS grade and risk in patients if you debulk beforehand. This will come into play even more if you have patients who are a little bit sicker at baseline and they may not handle severe CRS quite as well. Patients with CNS involvement, it's important to note that on every FDA label, they specifically say that these CAR T cell products are not intended for patients with primary CNS lymphoma. Trials are ongoing, investigating CAR T efficacy in patients with this disease, but it's just not there yet. Importantly, though, patients with secondary CNS lymphoma, they were included in lyso-cell. The response rate was 50% in the 6 patients who had that. When you're looking at organ function, we follow the inclusion criterion or SOP, but based on how well our patients have done and the low rates of toxicities and how well they're managed, we're probably going to be relaxing this requirement in the future. Currently, grant and clearance requirements are greater than 50 on our SOP. Heart function, high grade cytokine release syndrome does put significant stress on the heart. And so the current ejection fraction requirement at our institution is 45%, which is based on the inclusion criteria from those trials we've been discussing. But we have treated some patients with reduced ejection fraction as low as 30%. We treated them successfully and they've had good responses. And we've followed some of the additional cohorts from ZUMA-1, cohort 3 and cohort 4, where they use prophylactic tocilizumab and dexamethasone even before CRS developed to prevent CRS. And those seem to be effective measures to get patients like this through treatment and still have good efficacy. What about patients who need urgent therapy? What do we do for bridging? And so when you think about bridging therapy, the reason it's important is because these CAR T products take some time to be generated after leukapheresis. And so patients are waiting while the T cells are in the lab being made. And that can vary depending on the product from 2 weeks to 4 weeks. And during that time, if you have someone with rapidly progressive disease or disease that's threatening an organ, you have to be able to control it. And so currently the evidence we have for bridging comes from some subgroup analysis of the big trials that were done, as well as some retrospective studies. And I'll talk about some of that data right now. So in lyso-cell, they allowed bridging therapy, and they had a pre-planned subgroup analysis looking at patients who got bridging and patients who didn't. So 150 patients had bridging and 106 didn't. And of those, 101 responded of the 150 that had bridging, and 85 of the 106 that didn't responded. And the error bars cross over. So although there is a trend that bridging patients had lower response rates, it didn't reach statistical significance here. But there have been several reports suggesting that patients who get bridging therapy do worse. But it's important to know that who are you going to give bridging therapy to? You're going to give it to the sickest patients who have disease that's rapidly progressing. So in general, those patients probably aren't going to do well with any treatment you choose. And that confounding issue may be the reason that you see poorer outcomes in patients who get bridging therapy. So for example, in this study that was reported by Penix in 2020, you can see that the progression-free survival of patients who got CAR T cell therapy without bridging was better than the patients who got it with bridging. But then when you look at the actual patients in the study, patients who had bridging were had a significantly higher percentage of patients with poor performance status and a significantly higher proportion of patients with a high IPI score and bulky disease and an elevated LDH. And these are all factors that are associated with poor outcomes in DLBCL in general. So it's hard to conclude from this that it's really the bridging therapy that's the problem, and it may just be the disease itself that's the challenge. So how do you select an appropriate regimen for bridging therapy? So you need adequate disease control, especially in these patients with rapidly progressive disease, but you don't want to negatively influence the immune system, especially if you have to start bridging before leukapheresis. So it's been our practice, based on some reports in the literature, to try to avoid T-cell inhibitory agents, such as bendamustine, prior to T-cell collection. There's some evidence too that bendamustine, even during the bridging period after leukapheresis, may affect the T-cells that are behind and CAR T response, but that hasn't been proven yet. So it's also important to carefully consider use of any agent that targets CD19. So there's a couple of products out there, antibody drug conjugate, loncastuximab tesirine, and then the CD19 monoclonal antibody tafasitamab. And there's been a couple of case reports where patients have successfully been treated with CD19 CAR T after these products, but we're still careful to use these sparingly prior to CAR T cell therapy. There's also evidence from that paper that I showed you the picture from just now, that radiation as a bridge may lead to better outcomes and better disease control. It's an active area of research, and there's several publications that have been coming out early showing that it's well tolerated. In addition, there was a report from Liebers in 2021 where they showed improvement and good outcomes in disease control in patients who got a combination of polatuzumab with rituximab without chemo as a bridge to CAR T cell therapy. And the majority of patients made it through the bridging period, and 40% of patients had response to their disease just after one dose. So that might be a good one to consider as a bridge. All right, and then the last topic for patient selection, prior lines of therapy. So there's ongoing evidence that the earlier you give the CAR T cells in the treatment paradigm, the better they do. And there was a report last year at ASH of the preliminary results from ZUMA-12, which is using axi-cel in high-risk large B-cell lymphoma in, I would call it a semi-first line setting. So patients got 2 cycles of CD20 monoclonal antibody plus chemo, so R-CHOP. And then they got a risk assessment after 2 cycles. If they had ongoing PET avid disease, and they were included in the trial, they got leukapheresis, they could get non-chemo bridging, and then they would go on to get axi-cel. And then they looked at response rates of patients in this trial. And they actually found that 85% of patients responded and 75% of patients entered a CR. And so that's excellent in this group of very high-risk patients who had double hit, triple hit lymphoma, or who weren't in a CR after the first 2 cycles of R-CHOP. This is promising data, and there was evidence that the T cells that were generated as the CAR T product in these patients showed characteristics that suggested they may be more effective. And then this is an update from a press release in June 2021. And the formal presentation of this data is pending, but currently, based on the ZUMA-7 trial, which is a phase 3 trial in DLBCL, evaluating Yescarta or Axicell in the second-line setting, there's evidence that it improved event-free survival by 60% over chemo plus stem cell transplant. So at 2 years follow-up, they did meet their primary endpoint of improvement of EFS, and then also an improvement in objective response rate. And there was a trend toward improvement in overall survival as well. So this is interesting and important because it's likely to change practice in the near future. And places that are doing a lot of autologous transplant are going to be put in a situation where they have to decide, is CAR T cell therapy better in second line? Is auto transplant better? If we do CAR T cell in second line, will we still be doing auto transplant at all? So it brings up a lot of important questions that are likely to change the treatment landscape for DLBCL in the future. So talking about details regarding leukapheresis and manufacture. So currently our institutional requirement in order for a patient to be eligible for T cell collection leukapheresis is just an absolute lymphocyte count of at least 0.1. And there's been a lot of studies that indicate T cell manufacture success rates are very high, even with very low lymphocyte counts. It's important to know that the manufacture of the different T cell products varies considerably by product and by company, and averages between 14 and 28 days. But we've had some interesting experience with Axicell when it became approved for follicular lymphoma. Ever since that time, they've had a hard time keeping up with the production. And so initially, we were mainly using Axicell for our primary CAR T product, and it's been harder and harder to get it. There's about a 3 to 4 week waiting list just to be approved for leukapheresis slot now. So they're adding in additional manufacturing sites, but they haven't been able to catch up with production. It's important to know all those aspects of the different companies when you're trying to decide a product. In addition, it's important to know that Lysocell requires the manufacture of 2 different T cell products, a CD4 and a CD8 product, and both have to meet specifications in order for the product to meet FDA requirements and be used. So that may make it a little more challenging to get efficacious products. But in our experience, more than 95% of patients that we plan to give CAR T cell therapy to end up going on to receive it. The majority of that 5% or so that don't typically have disease that progresses too quickly, or they'll have a product that doesn't meet the required specifications. So they reported how many patients on each of those 3 major trials made it to infusion of CAR T cells and kind of what happened to those that didn't. So looking at Tisa-cel in the Juliet trial, 165 patients were enrolled in leukapheresis, but only 111 patients ended up getting infused. 7% of patients had failure of manufacture, and they didn't specify how many patients had progressive disease during that waiting period, but they considered them as other failures, and that was about 23%. For ZUMA-1, 91% of patients made it to infusion. Only 1% had manufacture failure. Only 1% had progressive disease, and the other 7% withdrew for other reasons. And then on Lysocell, about 85% of patients made it to infusion. Less than 1% had a manufacture failure, but 9% were out of specifications and still got the CAR T product on the trial. 10% had progressive disease that couldn't be controlled, even though they were allowed to have bridging therapy, and 4% came off the trial for other reasons. How about CD19 expression? So in terms of the inclusion criteria for the ZUMA-1 trial, it was not a requirement. The logic behind not having it as a requirement, they said, was that they believed the CD19 expression would be on pretty much all of the diffuse large B-cell lymphoma samples anyway. And then they went back afterward and took a look to see what the actual expression was, and they found in their ZUMA-1 trials 74% patients were positive, 8 patients were negative, and the rest we didn't have testing for. And it didn't seem like response rate correlated with the CD19 expression. But later, when they took another look at this, what they realized was that the antibody used for immunohistochemistry was not sensitive enough to detect expression in these 8 negative patients. And those 6 that responded were actually likely to be false negatives and were likely actually positive. In addition, there's been several reports of a loss of CD19 expression and CD19 mutations observed as an escape mechanism from CAR T cell. These mainly have been reported in acute lymphoblastic leukemia, but they've also been reported in lymphoma as well. So it's important to keep in mind. At our institution, we do routinely check CD19 expression, and we'll adjust our treatment plan based on whether it's there or not, especially if patients have had prior CD19 directed therapy. So now we can briefly touch on some of the toxicities associated with CAR T cell therapy. So the 2 most important are probably cytokine release syndrome and neurotoxicity, and those are the ones that are managed usually during the initial hospital stay right after patients get their T cells. Then additional toxicities include hematologic toxicity, prolonged cytopenias, infections, and hypogammaglobulinemia. And those tend to persist well after patients are discharged, and they can become chronic issues that have to be managed. So cytokine release syndrome is an acute systemic inflammatory syndrome characterized by fever, organ dysfunction, and it can be caused by various different immunotherapies and some severe infections. It's considered a supraphysiologic response to immune therapy, and it's mediated by inflammatory cytokines, macrophages, T lymphocytes, and endothelial cells. Patients will typically have fever, hypoxemia. They can progress to have hypotension, electrolyte abnormalities, cytopenias, elevated inflammatory markers, coagulopathy. Treatment is supportive care, and tocilizumab is FDA approved specifically for CRS from CAR T cell therapy. Currently, we have some ongoing issues with worldwide shortage of tocilizumab due to the increase in COVID cases and the use of this drug to help manage the inflammation associated with the virus. So we've had to adjust our SOP and do our best to try to manage with less toci available. And then corticosteroids are also an important backbone of control of CRS. So ICANS, or neurotoxicity, stands for immune cell effector associated neurotoxicity syndrome. The underlying mechanism is not fully understood, and there's a lot of research going on looking at it. It's related to systemic inflammation and circulating cytokines, leading to endothelial cell activation, disruption of the blood-brain barrier, and an inflammatory cascade in the central nervous system. Patients typically have headache, confusion, tremor, which can progress. They can have problems writing. They can eventually develop cerebral edema, seizures, and coma. And the mainstay of treatment is corticosteroids. And it's very interesting to see patients who have gone to the point of being severely confused with memory issues. They all look like they have something they want to say, but they just can't get it out. You start the steroids, and within a day or two, they're feeling much better. They tell you they can't remember the last couple of days. It's a very interesting process. So hematologic toxicity is also an important toxicity that's been observed in CAR T cell trials, and then also in real world experiences. And so some of those are described here in these 4 publications. So in the 119 patients treated with axi-cel and ZUMA-1, they looked at prolonged hematologic toxicity at 6 months. So this is grade 3 or higher neutropenia, anemia, or thrombocytopenia. They found that that occurred in 17% of patients. And then in these 3 additional studies at either with ZUMA-1 in 9 patients or single institution experiences, They found rates of prolonged hematologic toxicity at day 30 between 50 and 80%, and up to 60% at 6 months, and still about almost a third of patients with prolonged hematologic toxicity at 1 year. Looking at the associations they found, in this study, they found it associated with the number of prior lines of therapy and with the performance status of the patient. In this study, they found it associated with a poor 1-year overall survival. And in this study, they didn't comment on associations. At our institution, we found about 70% of patients who have prolonged hematologic toxicity at day 30 and a similar amount at 1 year. And we found it associates with the inflammation from cytokine release syndrome and then also with responses. Interesting. Infections are another source of toxicity after CAR T-cell therapy, and they can occur in almost a third of patients at grade 3 or higher. Usually the early infections happen during the initial hospital stay. It's related to the neutropenic period. It can be difficult to distinguish from cytokine release syndrome, but typically we start empiric treatment for infection as soon as patients develop fever, and then we de-escalate when culture turned negative. For the late infections, this seems to be related to the prolonged hematologic toxicity, ongoing neutropenia, B-cell aplasia, and hypogammaglobulinemia that occurs. And these can include viral, fungal, and bacterial infections. So we routinely recommend prophylaxis for 6 months or more after CAR T-cell therapy. At some institutions, they continue prophylaxis until they see recovery from B-cell aplasia. Hypogammaglobulinemia and B-cell aplasia, again, are due to destruction of the normal CD19 positive B cells by the CAR T cells. These can be prolonged for 6 months or longer and can be associated with late infectious complications. And we usually give IVIG in patients with low gamma globulins. So in summary, CAR T-cell therapy has excellent responses and outcomes in patients with relapsed or refractory DLBCL. There's currently 3 commercially available products, and deciding between them involves multiple factors, including the inclusion and exclusion criteria on the trials, the amount of time that it'll take for the product to be made by that particular company, and other factors. Patient selection is very important in terms of which product to use and in terms of whether or not you go with CAR T-cell. And understanding short-term and long-term toxicities is important for managing the patients receiving this therapy. So I can open it up for questions at this time.
Hi. Oh.
Hi.
Thank you so much. It was a wonderful presentation. I think you cover everything.
Thanks. Yeah, I kept going back to the questions in your case to try to make sure that I was hitting.
Okay.
Yeah.
Okay. We were waiting for any question for the audience, but I'd like to ask you just one or two. What's your opinion about what's your opinion as to outpatient modality of CAR T-cell therapy? Do you use outpatient?
So we're starting to do the conditioning as an outpatient, or the lymphodepletion as an outpatient. And then we're admitting patients after the infusion and keeping in the hospital for the first few days. And then we're planning to go completely outpatient after that. So one of the issues is with making sure the patients are close enough near our hospital during that follow-up period when they can have CRS and neurotoxicity. And we actually have a housing, like a hotel that's being built on campus right now. And once that's open, a lot more of our current inpatient treatments will move to the outpatient setting where they're going to be really close by in that hotel.
Mm-hmm. And in which situation do you still indicate allogeneic stem cell transplantation for relapse refractory?
So if patients relapse after CAR T-cell therapy, the treatment options aren't all that great. Like VR-POLA, which is one option. typically patients can go into remission for 6 months to a year, sometimes a little bit longer. And if I'm able to get a patient into remission after CAR T cell therapy, I'll typically start the workup for allotransplant at that time.
And in our case, the case that we have presented to you, how you select one of the 3 FDA approved CAR T cell for this specific case that I present to you?
For that case, I would say that I would go with whatever product I had the most experience with and whichever one could get made the fastest. So I feel like he met the inclusion criteria for all 3 products. So if I was more comfortable with one of the 3 from my own experience, or if I knew that I wouldn't have to wait if I went with one of them, that's probably the one I would go with.
Okay. Lucila? Cadê Lucila? Nelson?
Temos um Q&A, doutora.
Okay. Regarding Zuma 7 results, should you consider CAR T cell the new standard of care instead of autologous for relapse refractory DLBCL? Instead of?
It's possible. I think we need to see the final data.
Okay.
A progression-free survival benefit is always nice to see. It'd be nice to see if there was an overall survival benefit long-term too. I think the problem with giving CAR T cell first is that there'll still be a significant percentage of patients who relapse after CAR T, and they won't be able to get transplant at all now because we don't know what to do with transplant after CAR T. So I think it will probably change practice, and I think it'll probably change our practice here. I just hope that it doesn't eliminate that 10 or 15% of relapse refractory patients that got cured with auto transplant before.
I'm very impressed that the data that you present that more than 9% of the patient could receive CAR T cell in your experience.
Here, yeah, at City of Hope.
Nice.
Yeah, we're able to get our patients there once we get to that point. And I mean, we've had patients who we've had to keep in the hospital and manage, very hands-on during the time where the CAR T cells were being generated because they're very sick. And those patients, some of them have done well and some of them haven't. But yeah, the majority of our patients are able to get to CAR T cell.
Another question for the audience. What's your opinion with regards to early apheresis after first relapse for higher risk patients?
I think there's evidence that the CAR T cell product may be more efficacious if you're able to get it earlier. And so for high-risk patients, it may be a better option to go with CAR T cells. I mean, the preliminary data from Zuma 12 is interesting, and it suggests that maybe those patients who don't respond to chemo right away may have better benefit, better outcomes if they go to CAR T right away. But we don't have the long-term follow-up yet to know for sure.
And this is my questions. Which parameters besides lymphocyte counts do you consider to think about if the patient will be able to collect adequate apheresis products besides lymphocyte counts?
So even with really low white blood cell count numbers, I think our requirement is a neutrophil count of 500.
No.
As long as they have a lymphocyte count of 0.1, we haven't had too much problem collecting.
Okay.
Yes, very nice presentation. I would like just to hear a little bit more from you, because we have the data from Belinda that the Novartis had the press, and now we have the Zuma 1 and the Zuma 7, and we have the Transform as well. So maybe this really had the impact in how we manage these patients. But we have we will participate in the Belinda trial, and we know that it's difficult when the patients relapse after CAR T cell, and he didn't do the autologous. And we know that we have some possibility with the new drugs, but this is not going to be the reality for here in Brazil, for example.
Okay.
And it's a little bit difficult because if the patient didn't go to the autologous transplant and then they left about the CAR T, and we have this situation here, and we didn't really know how it's gonna be after that. If they should go for haplo instead of the autologous. So if you could talk a little bit about this, what do you think will happen? This is one question. And the other thing is gonna be, for example, the use of some drugs that you know that could make the lymphocytes better, like for example, ibrutinib. We know that we have some data, preliminary data that ibrutinib could make the function of the T cells, improve the function of the T cells. So what do you think as well that could be a good approach to do like a bridge, like before the leukapheresis, the ibrutinib, and then maybe like bridge as well and continue? What do you think a little about this?
All right. So as far as patients who, if the treatment paradigm changes and we go to CAR T cell after first relapse, I think that it'll be hard to take patients to auto transplant at all. We have absolutely no idea, what's going to happen. We don't know if chemo sensitive disease at that point will translate to good outcomes after auto transplant. I'm sure somebody somewhere will start to investigate it. I don't know if they'll do it in a trial because I don't know who's going to pay for the trial unless there's some additional therapy added on top of the conditioning. But retrospectively, there may be centers where they're doing that just to see if it's beneficial or not. I think right now, my experience is if patients relapse after CAR T, I typically try clinical trial therapy, molecularly targeted therapy, some of the newer antibody drug conjugates. And if I'm able to get a patient into remission and they're healthy, then I'll typically go toward allotransplant if possible. And then as far as agents trying to add on to CAR T cells to make the T cells more efficacious, I think that's kind of an exploding field. And I've seen a lot of trials starting up looking at that. I think it's really interesting. I think it's really important. I think that two of the most important factors are when to start it, to make sure, that the T cells really get the benefit of having it started. Does it just need a few days of ibrutinib before you collect? Is that good enough? Or do patients need to be on it for a while? And then afterward, how long do they need to be on it? And are there drugs that can keep CAR T cells around for long-term surveillance? I think if we could figure that out, then probably the relapse rate would drop and the long-term survival would probably improve. So I'm interested to see more results as those come out for sure.
And more, I think we are almost
This
done.
will be the last one.
Yes, sorry, do you want to ask, Doctor?
No, you're.
No, more practical question, actually. So I know that we receive patients around the world to receive the CAR T with you. So usually after the patients come back to the center, usually you give to the center the guides with the vaccine, all the guides, and after, for example, 30 days, after the infusion, you allow them to come back to the center, or you wait a little bit longer, for example, 3-4 months. Not 3 is too much, but 2 months, and then you guide the patient to come back to the center, even if the patient still have cytopenia or some kind of late toxicity.
So typically we'll have patients stay very close to the hospital for the first 4 weeks after therapy. And then they have to stay within a short distance from some center that could manage them if they develop late neurotoxicity. But then all those other late toxicities you talk about, we do allow them to go back home with those quite often. And we try to stay in communication with the physicians that send us the patients for the consult and help them manage them. But yeah, I've had several patients who I communicate with, I have like telehealth visits with, who still have ongoing low blood counts and have to stop in and get Neupogen and IVIG infusions like a year or so after their CAR T. But they're managed by their own home oncologist.
Great. Thank you.
Okay, thank you so much, your
No, no.
time. It's wonderful. As I said, the presentation cover everything that I think it's very important for us that we're starting to think about this treatment. And as Lucila told before, it will be a very pleasure if you have some kind of collaboration. And if you don't mind asking, because I'm finishing some procedure, you have some kind of practical questions, and maybe you can help us.
Absolutely.
Okay. Okay.
Be my pleasure.
Hi.
Thank you.
Congratulations. Thank you.
Okay. Thank you so much.
Thank
I
you.
think that. Oh, okay. No more questions.
All right.
Bye.
you, guys.
Thank you so much. Bye, Kosana. Bye bye.